Good morning. I can't believe that it is 10 years. I was only 21 when I first joined the programme here. But it has really been a pleasure for us to do this, and we've tried to innovate the programmes over the 10 years. And looking back when we were getting ready for this event, the original things, we designed our own flyers, and we did on a very small shoestring. Maggie and I would do all the audio visual. We'd bring our own laptops, speakers and everything. We've got a lot more sophisticated, as Mandy said, so it's really come a long way, and we're quite well recognised on the South Coast for what we do around patient education, around osteoporosis. But it is a lifelong event that needs to, or lifelong lifestyle changes that need to be adapted and are recognised as an impact on bone health and osteoporosis. So we recognise that if we start from a young age and we start with our children and our grandchildren, teaching them about bone health, what's good for them and what's bad for them, they're actually starting to build a good bone stock for when they get into their older age, when the bones start to deteriorate due to the natural cause of ageing. And that's for men and for boys and for girls. It is more important for women because of the estrogen changes around the menopause, but all of us are potentially at risk for one reason or another through our lifestyle if we don't adopt good lifestyle practices. So what we know about bones is that they are a living structure. Lots of people think that once we've got to a certain age, around our 20s, 30s, that our bones never change and they're there for the rest of our lives, but that's false. The true fact is that these bones are constantly changing the internal structures and external structures, maintaining good nutrition to the bone areas and also maintaining good quality of bone. There are a number of factors that may interfere with that process, but in general the bones themselves are turning over on a frequent basis. They're also an important area for storage of calcium and other minerals. And what the body does is, when it's got sufficient amount of calcium and minerals, it will lay those minerals down into the bone. And when it needs them, because there's a shortfall in the minerals, it will call for the bone to release those minerals back into the circulatory system to help with other parts and functions of the body. And calcium is the biggest one, and calcium has a number of benefits in the body. It helps with muscle strength, is vital for heart and muscle contracture, so it is an important mineral. We need our bones for movement. If we don't have good, strong, healthy bones, we find it difficult to move. And also the bones have a function for red blood cells and other blood cell formation. But in osteoporosis, why does that happen? Why do we develop osteoporosis later in life? And it's really due to the two cells called osteoclasts and osteoblasts. And for one reason or another, they are either in balance with each other's tune and not working together. So what will happen in general when an osteoclast recognises that bone is slightly worn or slightly changing and needs replacing, the osteoclast will go in and reabsorb that piece of bone. Once it's done its job, the osteoblasts will come in and lay down new bone. Now, for one reason, I said there's either the osteoclasts are more active, so they take away more bone than the osteoblasts can replace, or the osteoblasts really just can't keep up for a number of reasons, and I'll explain those as we go through some of the talk. So osteoporosis is this deterioration in this structure of the bone, and you'll see on the top-hand slide what normal bone looks like under a microscopic biopsy. So someone has given up a bone biopsy, and you can see there's a nice, strong honeycomb structure. Within that structure, you've got areas that are thick and really well formed. There are some breaks in the bone, but that's not necessarily abnormal. What you can see on the osteoporosis slide down below, which is a further biopsy, you can see that both the structures are thinner and there is more spaces where more bone has been lost. And it's that causes these bones to be more fragile and likely to fracture from low trauma. And we know that if you do have a fracture associated to osteoporosis, that fracture can lead, depending on which bone it involves, into long life pain and also changes in body shape and also disability. We know now that we used to talk that women was perhaps 1 in 3 women, but the statistics now say 1 in 2 women over the age of 50 are more at risk of osteoporosis now, and 1 in 5 men. So we're seeing this epidemic of osteoporosis really changing, and there needs to be something that's done to try and revert that problem to the health economy. What you can also see on the bottom slides is really why, when people are more at risk of different fractures. So we tend to fracture in our 50s, more things like our wrists. And that's because we often fall over by mistake from a standing height, and we'll have what we call a low trauma fracture. But it's a good indicator, and Claire from the NOS will be talking about the Stop at One campaign later. But it's a good indicator if you're 50 and you've had your first low trauma fracture that someone needs to look into it, and that's why the Fracture Liaison Service was brought into place. We do see vertebral fractures also occurring, but these are often silent and don't really come to the forefront for about another 5 to 10 years. But the other reason why it's important to treat people early on in their 50s if they have their first fracture and they've got osteoporosis, because we're trying to stop hip fractures for the people in their 80s and 90s. And Dr. Youngmin, when he talks today, will show you some staggering figures that we've actually reduced hip fractures in the Hampshire area, or in our area, dramatically with just 2 years of work from the Fracture Liaison Service. You normally don't see that type of curving change for about 5 to 10, but we've seen the first real positive impact on the Fracture Liaison Service at 2 years. So there are numerous risk factors that will affect osteoporosis. I'm going to talk about women's health first, and then Dr. Samet, who's one of our registrars, is coming to talk about men's health. But it's really to recognise it's not just one component. It is often a number of different factors that contribute to us developing osteoporosis, whether it be another comorbidity such as rheumatoid arthritis. It may be the fact that our age is a component of it. It may have been that we've been a smoker, lifelong smoker, and our osteoporosis is a contributor to that. So it's not just one thing often, it often is a numerous factors. So, women's health. I must say, I've been doing osteoporosis nearly 25 years now, and when I first came into post doing an osteoporosis role, really, men weren't being considered at all, and it was predominantly deemed to be a women's health problem. It was acknowledged that some men would have health problems associated with osteoporosis, but in predominantly, I would see clinics full of ladies talking to me about, for me to talk to them about their osteoporosis risk factors. So it's a campaign that we want to do is to raise awareness of any woman who has lifelong risk factors to talk to their healthcare professional about their potential risk factors for osteoporosis in combination with whichever health problem they have as well. And my colleagues, female colleagues will like this because they think that I'm quite sexist, but actually we recognise that women throughout their lives have key roles. And often they are the person, or the person in the family is the axle, which around the family and also sometimes society revolves. And it's about that understanding that if we don't look after our women for whatever age they are, then we're putting them at risk for later on in life when they perhaps want to have a bit more of a rest. So it is about lifelong investment in bone health. The other striking fact is that we are living longer for both men and women. This is the projection for 2011. The majority of the population are now expected to live, females into their 80s and men into their late 75s. And the projection is that later on, in 2020, we'll be expected men to live in our early 80s and women into our late 90s. So more women and men will be living a lot longer. And it's that lifelong living with osteoporosis, if you first develop it around the age of 50, that we've got to protect your bones so your bones are strong throughout lifespan. So for females, and for men really, we need to invest in our children because this is the important time of their development of their bones. We see lots of children drinking fizzy drinks, and fizzy drinks are thought to leach calcium from the bones. We see that our children are a lot less active. They're spending more time on laptops and PCs and playing games than they are out in the sun, playing football or playing netball. And it's that lifelong or that early investment up to in our 25s, 30-year-olds, when we will get what we call our peak bone mass. Now, women will never achieve as much peak bone mass as men, mainly because of a number of factors. Men tend to have stronger bones anyway, and there may be something to do with the male hormones. But we do want to make sure that our women in their 30s have achieved their peak bone mass. If for one reason or another they haven't, then they often start to at a lower level of bone density, so when they hit their 50s, they're already at a higher risk. And there are a number of contributing factors such as diet, exercise, the menstrual cycles and things like that, which can contribute to women not achieving their peak bone mass. We then know that around the age of 45, 50, depending on when ladies have their menopause or surgical or natural menopause, that they start to dramatically lose bone for a period of time. And that's the loss of the estrogens that's a contributing factor. But then they do plateau a bit, and then the last lot of phases of the bone loss is really associated to the natural deterioration of bone as we get older, not necessarily due to any other reason. Although if you're on steroids or other treatments, then that bone loss may be more dramatic. And it is a bit about pot luck, really. There are things in our lives that we cannot change. The genetic risk factor for osteoporosis is something we cannot change. We cannot determine who has the genetic components. We can identify that if your mother had osteoporosis and an osteoporotic fracture, the likelihood is that it may be a genetic factor. And there are some rare conditions in boys and girls that are born or quite young on they're diagnosed with osteoporosis that may be associated to genetics. We can't really sometimes influence other comorbidities. So if we have things like epilepsy and we're on medication for epilepsy, which we also know may be a contributing factor, we can't necessarily change that. We can't change when you're going to have your menopause. That's something that's kind of determined. Some people have to have earlier menopause, such as surgical menopauses, which may be a contributing factor why they lose bone earlier. Also, we see that breast cancer and other cancer treatments may come into our lifespans, which once again may affect osteoporosis and bone health. And then as we get older, our eyesight changes, which may make us more prone to falling. We can do something about that, but there's people who've got diseases such as macular degeneration where the eye function is deteriorating. We can't necessarily do too much. And then also falls. Now, the falls girls are here today, and I'll just plug is that we shouldn't recognise that anyone who falls over the age of 50 is a natural fall, that it's something we should expect. If you are falling more than once or twice, then it should be something that you have a discussion with your healthcare professional about, because there may be contributing factors to falls. So often the falls are associated to over-medication. Someone's giving you 10 lots of different medications, they interact with each other, or no one's reviewing them, and you potentially are on too much of a medication that makes you drop your blood pressure, which contributes to a fall. So fall should never be accepted as something that should happen to the older person. It's not a norm. But there are lifestyle changes that we can choose. So we can choose to live a healthy lifestyle, getting out there and getting the vitamin D. We can choose not to smoke. We can choose not to over-exude in alcohol. We can choose a healthy diet. We can choose to be active. We can choose to take the medication for osteoporosis. And one of the things that's come out of the fracture liaison service is really the number of patients who at 18 months, 2 years, or even earlier than that, have just chosen to stop taking their medication that's controlling or improving their bone density. And also, we can do something about slip, trips and falls at home. And once again, it's recognising there may be risk factors that at homes we have loose carpets. My gran was notorious for putting a mat on top of a mat. When the hole appeared, then she put another mat on top of that. Suddenly you'd have 4 mats and carpets on top of each other. It was a notorious trip hazard for her. We can also choose not to drink too much fizzy drinks and drink more calcium-rich drinks. And we can also choose, once I said, to be more active, not spending all day on the computers. So estrogen is one of the key factors in women's health and why women will lose bone health after either a surgical or a natural menopause. And estrogens work in a number of ways. They work on stimulating the osteoblasts and osteoclasts to do their job properly and help them keep this balance correctly. And it's with the loss of the estrogens that this imbalance starts to occur more frequently. And what you can see on this side is that a woman pre-menopausal period, their bone health and their estrogen levels are normal, and what happens during the phases leading up to the perimenopausal phase, they start to have irregular periods of estrogen levels, which starts to impact on the quality of the bone. And then after they have their last period, then the estrogen levels are at a lower level, which contributes to the menopause and then also to osteoporosis potentially. So there are numerous causes for early menopause. They're all listed here. There are a proportion of people that have a family risk. So if you are a female generations and you notice that 2 or more in the family of the females have had an early menopause, it may be a genetic predisposition. There are things like diseases such as thyroid disease, which may contribute to an early menopause. Also overweight or underweight, and we know our young girls who are anorexic often lose their menstrual cycles quite early and never restore them, so therefore their estrogen levels are considerably depleted. And also we know that smoking is a contributing factor to an earlier menopause in women. So the population, about 1% of women will go through the menopause before the age of 40, and that's a natural, not a surgical menopause. And then there are a small proportion of women who do go through the menopause before the age of 30. So, 0.1% will go before the age of 30. So there are some women who are particularly at risk, and so we try and do some work with our gynecologists to make sure that they understand that these women need to invest in bone health, education and awareness from the stage when they first go through their menopause. And what we say is that what we're aiming to do is capture these women early on so we can prevent them having a fall and causing a fracture to their wrists, their hips or their spine, and also to keep their bone density in a level whereby they are a lower risk of fracturing. If they've got good bone density and they have a fall, then the likelihood is that they won't fracture. Breast cancer has been one of the things that's been an area of concern for people in the osteoporosis community, mainly because the treatments that we use in breast cancer may contribute to bone loss, especially the new aromatase inhibitors. Once again, the good news is, and the breast care team are here today, is that although the incidence of breast cancer is increasing, the actual survival rate of our women now is a lot better than it ever has been. And we have seen that we're seeing an improvement in the care and quality of these patients over the time, and so their expectancy to live is a lot better against some other conditions such as lung cancer, which is still on the increase. So there are a number of treatments that will be offered to women who have breast cancer. Some of them get both options as a protective mechanism. Some may be just offered one or another. But chemotherapy is one of the most common factors or common treatments used, and often can, if the woman has not had a menopause, cause an earlier menopause or ovary dysfunctioning. And what those chemotherapy drugs are doing is actually inhibiting the osteoblast or osteoclast from doing their job correctly, as they destroy those cells potentially as well. Sometimes we use treatments to suppress the ovaries as well, because if it's a cancer that's driven by the hormones, then suppressing the ovaries may actually reduce the spread and also the complications associated with breast cancer. A drug called tamoxifen was brought on the market some time ago. If it's used in premenopausal women, it seems to perhaps cause more osteoporosis than if it's used in postmenopausal women. But it is a drug that has once again improved that life expectancy of our women these days, but has to be taken. If they are taking this medication, the breast care teams need to be talking to the patients about lifelong bone health, education and lifestyle changes. But the aromatase inhibitors, the newer one, the anastrozole, and those ones are the ones that probably are the biggest contributing factor. And once again, they reduce the amount of estrogens that are circulating in the body, which once again then reduce the bone loss. And so the NOS have a very good leaflet on aromatase inhibitors that if you have been on those treatments and no one's talked to you about bone health before, that you can show to both your GP and your oncology breast care surgeon, just to make sure that they are aware that you're interested in your bone health. And these were the graphs really that shows that these treatments do inhibit bone health. So what they're showing here is the bone density of the lumbar spine projected, and once you start treatments, how quickly you lose bone. So it is, sometimes it can be as early as 2 years onto treatment, but earlier than that potentially. But it can be a bit longer, so up to 4 years, 5 years. If you're on these treatments lifelong, the risk of your bone density dropping is quite high. So what can you do? You can ask your breast care teams and your oncologists or your radiotherapists about osteoprevention and aftercare for breast care patients. So smoking is another contributing factor. And as I said, smoking seems to be associated to earlier menopause in our women. Smoking consumption has started to decline. So you can see on this graph the number of smokers per population, or the percentage, is actually dropping. Unfortunately, it has been replaced by e-cigarettes, and I'll just talk to you about that in a minute. But we know that smoking is a considerable factor for both estrogen levels, but also smoking may be contributed in another indirect way. So smokers tend to be thinner, and therefore they don't have such a good bone muscle mass. And we know that if you're slightly overweight, that's good for osteoporosis because that helps to stimulate the bones to change over the cells to stimulate to change over to new bone. Smokers tend to drink more alcohol, which is another contributing factor to osteoporosis, and they tend to be less active, and it's thought that the research would suggest that they often have poorer diet. So if you are a smoker, in addition to the potential, if you're a woman, the effects on the menopause, it cannot contribute to a number of other health reasons which may be causing your osteoporosis. Passive smoking, there's been one study that suggests that even passive smoking during childhood may increase the developing osteoporosis and low bone density. So we shouldn't once again just think about ourselves, we should be thinking about our children and our grandchildren. If they are in environments where people are smoking, in cars or in the house, they may be just slightly putting their bone health at risk later on in life. The other thing for those of you who have osteoporosis and you've had a fracture, fracture healing is often slower in those patients who are smokers. Once again, it may be when the smoke, cigar and tobacco contents actually inhibits the osteoblasts from doing their job properly, building new bone. But often smokers have a different or poorer circulatory system, so therefore they're not getting the nutrition to the area of fracture healing. So if you're a smoker, you can expect your bones to slightly take longer to heal. So the controversy of e-cigarettes. So e-cigarettes was thought to be the wonderful answer to smokers and to help people give up smoking. I would suggest from some of the reading the evidence that actually e-cigarette smokers do not necessarily then wean to be non-smokers. They seem to be a continuous answer, or continuously relying on the e-cigarettes. The NOS on their webpage now have got a statement around what the impact of e-cigarette may have on osteoporosis. And there are no long-term large clinical studies at the moment, but the influence is that e-cigarettes may not be as safe as everyone thought they may be in both bone health, but also in fractures, but also in other healthcare or health long-term conditions. So although they're on the way to improving, they haven't really answered all the problems that stop these people smoking and cause problems due to the cigarette smoking, such as cancer, osteoporosis, heart disease. So if people say they're doing the e-cigarette because they're a lot more healthier, then ask them where the evidence is, because there isn't the evidence out there at the moment. When you ask people how do they give up cigarettes and why do they give them up, most of the people are using the e-cigarettes to give up smoking. But actually, if you look at the youngsters, and I was surprised to see the number of 16, 17-year-olds who are now buying e-cigarettes. So they haven't really had lifelong exposure to tobacco, but they are now reliant on e-cigarettes at a very younger age. And as I said, you can see cigarette smoking has come down. The actual sales of e-cigarettes are exponentially increasing year on year. And it's supposed now to be a multi-billion business. So what can you do in relation to smoking? Quitting smoking, if at all possible, because it can help improve bone density, but also will help with fracture healing. And also consider giving up smoking of the e-cigarettes. And Portsmouth and Hampshire alone have a number of smoking services that you can access. Some of them are online, some of them are face-to-face, and some of them are telephone support lines. So there are a number of resources out there to help smokers. So alcohol in women and osteoporosis, and it's always thought that alcohol, the problem of alcohol was improving, but actually there may be some evidence to say that abuse of alcohol is increasing. So why does alcohol affect bone? It affects mainly because the parathyroid hormone, which helps to regulate the body's calcium levels and phosphorus levels, may be interfered. The increased alcohol increases the parathyroid hormone levels, and if they remain high, they put a strain on the body's calcium reserve, and therefore taking calcium out of the bone and putting it back into the system. There is evidence to say that alcohol will interfere the absorption of calcium from the diet, mainly because it interferes with these liver enzymes that are important to convert inactive forms of vitamin D to the active form. So if you are drinking a significant amount of alcohol, then although you may be exposing yourself to enough vitamin D through sunlight or taking the calcium supplement and vitamin D supplements, you may not be getting the best you can from the treatment. Excessive alcohol also is known to damage the pancreas, and once again, this is where this enzyme is often produced, and what we need for the absorption of calcium and vitamin D from the intestinal systems. And also, alcohol is its ability to increase this cortisol level, and cortisol is a steroid-type hormone the body produces naturally, which once again reduces the work of the osteoblasts, which means that less bone is formed. Also, we know, the same as smoking, that people who drink tend to replace alcohol drinks with, they replace milky drinks with alcoholic drinks. They tend not to have the late night milky drink before they go to bed. They often have a glass of wine and they think that's sufficient. So it interferes with a number of reasons in the body and systems of the body, and also people taking other appropriate healthy diet lifestyle choices. So it's associated also, people tend to smoke more if they're dependent on alcohol, and also the risk of falling. So there was some research about women who are drinking more and more at home. So where men tend to drink external from the home, there's a thought that women actually are starting to increase drinking at home. They often finish a bottle of wine themselves rather than sharing it, and often there are now women who are reporting that they're drinking more than one bottle of wine a night. And we're seeing the increase in population of people admitted to A&E due to alcohol throughout the age ranges. So even our 85-year-olds and 84-year-olds are ending up in A&E because of alcohol consumptions. So it is important that we recognise that there are recognised appropriate levels of amount of alcoholic drinks to take in a week. And once again, we have the alcohol awareness team here who can talk to you about what's good amounts of alcohol to drink and not to drink. And the recommendations do keep slightly changing, but it's about 2 to 3 units for a woman and 3 to 4 units for a man. And often people presume that a whole glass of wine is a unit, but it's actually quite a low amount of wine is a unit. But as I said, the alcohol support team are here, and they can talk to you through about what your alcohol consumptions are if you want to. So, what can you do is really improve and review the amount of alcohol you're taking, and also speak to someone if you are concerned about the amount of alcohol you're reliant upon. The other one which is important is a sedentary lifestyle. So if women are having early menopause, if they keep themselves fit and active, then the likelihood is that they will help to stimulate the new bone to be stronger. But because sedentary lifestyle is also associated with alcohol, smoking and weight changes, then often we have this imbalance once again. So the guidelines really are for all of us over the age of 19 is that we should be doing a mixture of exercise, different forms of exercise over the week. Now they talk about 150 minutes of moderate exercise over a week and some components of stretching exercise. Or if you are the sort of person that gets the fix from doing quite more vigorous exercise, you can do less exercise, about 75 minutes of exercise spread over a few days, and then also once again building in some stretching exercises. We have our physiotherapy team are going to be here later today, and we also have the Falls team here from Southern who once again can talk to people about how to get more active locally. And also if you live in the Portsmouth area, Paula Day and the health improvement team are here showing you what exercises or directing you to exercises that are available locally. It's about having this mixture. It's not about just doing one form of exercise. When we ask patients in clinic, do they do any form of exercise? Most people say, well, I work or I walk every day. If you're doing that on a regular basis, yes, you are probably maintaining your bone health, but you're not necessarily improving your bone health. So you do have to challenge the body a bit more if you want to increase your bone density. And as I said, the physios are here to give you some advice. But what we are seeing that over the years, our older population, or in our 40s to our 80s, we're really not achieving the amount of exercise that we should be doing. And often people perceive that as because the healthcare professionals want you to join an expensive gym or something like that. We're actually saying there are lots of things out there in the community, and today you'll see two of the groups of ballroom dancers are going to do a lunchtime demonstration of ballroom dancing, because ballroom dancing helps with both, it's a stamina exercise, it helps with balance, and it's also weight bearing, so it actually ticks the box for lots of your exercise. So if you like ballroom dancing, get back there dancing, and you'll meet Craig Revel Hall lunchtime as well. So it's important that everyone gets active, and women especially looks at their activity to improve the amount of exercise and activity they're doing over the course of the week. And as I said, we've got the health and wellbeing team here today to support you. So my last really thing is join us in this campaign. You ladies have really banded together over the years. The war years, we saw all our ladies getting together to do things like Home Guard, doing on Land Army. But it's about time you banded together to really address the issue of osteoporosis in the community. Supporting the local support group, getting the message out there that you can do something to improve your bone density if you make the right lifestyle choices. Even if you've had an early menopause and you've lost your estrogens, you can still improve the bone density throughout a number of ways. So thank you.